Hello everyone, I'm Dr. Carter Newton, a cardiologist and radiology faculty member at the University of Arizona. And on behalf of my co-chair for the 5-day CTA course at Chandler Regional Hospital, that is Dr. Roger Bees, I'd like to welcome all of you who will be traveling from the Kingdom of Saudi Arabia to Phoenix, Arizona in about 2 weeks' time. On behalf of the staff at Chandler Regional Hospital, both the medical and technical staff, Siemens Medical Solutions, Virtual CME, and Dr. Bees and myself, we'd like to welcome you and tell you that we're really looking forward to having you attend our course. A lot of work has gone into making it a productive program for you, and we hope you're anticipating it with the same excitement that we are. I'd like to just take a little bit of time to prepare you for what to expect and maybe to review some basic key points about CT angiography, cardiac anatomy, some of the vocabulary of cardiology that be used in your reports. A few comments about general atherosclerosis, the disease process, how to use the workstation viewing tools, and the reporting of findings. We'll go over this in much more detail, but maybe to get us all on the same page, I think some key points are important. I'll try to speak here for about 20 minutes time to get us all on the same page. First, some clinical fundamentals. This is a tool which is meant to study an incredibly important disease throughout the developed world and the underdeveloped world for that matter. And these statistics are American statistics, but they would probably apply in similar percentages to population in your country. And that is to say that in a country of about 300 million people, about 700,000 acute myocardial infarctions occur annually, and in half of the time, these are fatal events that have occurred with no prior symptoms. Perhaps as many as 600,000 people every year die of one form of heart disease or another. And it's a disease that affects both men and women and is in fact the leading cause of death in both sexes. And the cost to the economy is tremendous, probably exceeding $500 billion when the accountability of lost wages, lost productivity, and the cost of care of disease relating to coronary atherosclerosis is taken into account. It's a chronic disease. It has a very long preclinical indolent state, which may be decades in length, let's say beginning at late teenage years and progressing for 3 or 4 decades before it becomes symptomatic. And as I mentioned earlier, about half the time the presentation is some form of an acute coronary syndrome, and this might be an acute myocardial infarction. It might be the development of unstable angina pectoris, or it might be a sudden collapse with cardiac death. The cause of the fatalities that occur with coronary atherosclerosis is a condition that really relates to the underlying plaque in the wall of the artery. And typically a thrombus, that is a aggregation of fibrinogen, platelets, etc., occurs at the site of plaque ulceration, typically on a plaque which is either fissured or ulcerated, has become inflamed, and there is the mechanical obstruction of blood flow. So in theory, everything distal to that particular plaque is in jeopardy, and it's only a matter of minutes really before actual myocardial necrosis begins to occur. It is important to show, however, that ulcerated plaques are present in many coronary arteries that do not, for some reason, attract the thrombus formation, and that thrombus, once formed, may spontaneously lyse and break up. It is not necessary that everyone receive percutaneous coronary intervention, for example, or thrombolytic therapy. Many plaques probably form and briefly occlude flow to some degree, perhaps completely, and then lyse spontaneously, and those plaques go on to ultimately heal and leave a scar, perhaps some degree of stability of the vessel wall disturbed in the formation of calcium. Anyway, an unlysed thrombus is a cardiac emergency. It may or may not be recognized, but after about 20 minutes and for as long as about 4 hours, a myocardial infarction in evolution may be occurring. And of course, the outcome depends on the size of the myocardial infarction to a large extent, However, even small myocardial infarctions can be associated with spontaneous development of a life-threatening arrhythmia, and typically this is the final arrhythmic common pathway that occurs with ischemic coronary artery disease, and that is ventricular tachycardia, which often deteriorates into ventricular fibrillation. That said, we now have guidelines for cardiac CTA, which have been developed over about the last 10 years, and these are guidelines that have been the results of both observational studies and randomized clinical trials. And we have about a dozen common indications, this being particularly important here where the payment for the services for treatment of coronary artery disease, interventionally particularly, is determined by the patient's insurance companies. So it's been necessary to develop strict guidelines of when a coronary CTA is clinically important and when it's not. But these are some of the indications, and I'll just mention a couple of them, particularly something like the preoperative assessment prior to non-cardiac coronary surgery, for example. Also, patients who have discordant physiologic testing, for example, PET myocardial perfusion, where ST segments are noted to change or where symptoms may develop, and yet imaging is not consistent with the expected ischemic findings. Risk assessment following revascularization, particularly if there's been a return of pre-revascularization symptoms. And of course, there's a wealth of information that can come over a studying of the ventricular morphology and systolic function, perhaps in determining the likelihood that an implantable cardiac device may be necessary, congenital heart disease, and the search for non-cardiac masses, a thrombus, a tumor, for example. These are all appropriate indications, and you can make a note of these, and we'll provide a list of all these at the time of your course attendance. Well, if we look back on the last 12 years, things are getting more and more exciting for cardiac CTA because its applicability is more definite, its value is clearer, and the number of studies which are being ordered is increasing. And somewhat slowly, the acceptance of non-invasive coronary arteriography is working its way into the toolkit of workup of ischemic coronary artery disease. It's typically now very widely available, particularly with multi-slice, that is, scanners of 64 slice capability and greater. It's a quick study, doesn't take long, as you will see. And basically, it's driven by protocols that are very patient-specific, and these are simple. And normally, there's not a wide variety of these. Particularly, radiation-sparing protocols are important as we begin to bring younger people into consideration for CTA, both children and younger women who may be in fertile years. The images are frankly a lot better now. That is, most specifically, there's better contrast resolution of structures. The edge detection is better. There's more detail. And there's been a great deal of reduction in noise in the signal. The dye doses have been reduced. The amount of radiation exposure has been reduced. And above all, it's been determined by evidence-based studies that the post-test results in properly selected patients are valuable and will actually direct care and particularly be important in established prognosis and the intensity of management. This was initially basically a proximal large vessel procedure, which is fortunate in a way because most of the important vessels are large vessels, or they are proximal vessels. But we really never had the ability to characterize the plaque much. We could come to not really a consensus, but a pretty good repeatable approximation of whether a stenosis was likely to be obstructing flow or likely to be not obstructing flow. Now our resolution of smaller vessels with plaque characterization is routine, and now it's routine to be able to obtain wonderful CT imagery at doses of 5 millisieverts or less. And with this, we've gotten functional chamber anatomic information. It's now developing usages in anticipation of valve replacement surgery, particularly the transvascular aortic valve replacement, which is now growing in popularity. And there will be soon transvascular mitral valve surgery and mitral valve replacement as well on the horizon. So the valvular applications will be important. And now that the dose has come down, we'll be able to do dual scanning myocardial perfusion studies. And there are complex software programs that are analyzing the flow characteristics that we see in cardiac CT to try to help discriminate whether a particular plaque is likely to be a plaque that is truly capable of producing myocardial ischemia and therefore being functionally significant to explain a symptom or an abnormal perfusion study. Well, let's take just a minute and review some basic anatomy. You all know this, but just so we are speaking the same language and so on, recall that the aortic root is the segment of the ascending aorta below the sinotubular junction. There are typically 3 sinuses of Valsalva. The non-coronary cusp really, even in consideration of anomalous coronary vessels, virtually never gives rise to a coronary artery. But the left and the right coronary arteries typically emanate from the left and the right coronary sinuses. And typically we develop 2 of these vessels. The left main coronary artery and the right main coronary artery have a slightly different vocabulary. The left main is typically a vessel between 4 and 6 millimeters in diameter, and it can be very short. It can be up to several centimeters in length, but it's typically about 1 centimeter in length. And almost invariably, this vessel bifurcates and divides into a left circumflex artery and a left anterior descending artery. The right artery is commonly called the right coronary artery, and that, rather than calling it the right main, it could be called the right main, but this is essentially a circumferential vessel throughout its course. And it finally, at the bottom of the heart, gives rise to a posterior descending vessel. Just a bit more about terminology: the circumflex, the left anterior descending, the left main, and we describe segments as according whether they're proximal, mid, or distal. And then we describe the branches. For example, diagonals always are the anteriorly directed branch vessels off the anterior descending artery. Septals are the vessels that are penetrating the interventricular septum. Branches off the circumferential artery, the left circumflex or the right circumflex, are all called marginal arteries. And there's always a bit of confusion and mix-up on how we name things. What do we really call this? What do we really call that? And it takes very little time to come to a very intimate familiarity of the variety of coronary profiles, but they're all very similar, with the exception of some anomalies which are also common and we'll discuss and go into detail at the time of the course. The right coronary artery could be called the right main. It could be called the right main circumflex. But the important vessel here, which is often underestimated in size by CT, is the posterior descending coronary artery, which emanates after a long course around the circumferential margins of the heart to the inferior cardiac surface. Then let's talk a little bit about what atherosclerosis can do. This is actually becoming clearer and clearer as we develop greater and greater research understandings of what's involved when a plaque forms and what the natural history of phases of inflammation and healing that takes place over and over again in these vessels. Frankly, if an artery occludes completely, particularly if it's sudden and particularly if it's proximal, a large myocardial infarction can certainly be the result. Symptoms don't necessarily appear immediately. They can be minutes, maybe 10, 15 minutes before a person becomes aware clinically that something is going wrong. ST segment changes on the electrocardiogram often precede that. This is followed by wall motion abnormalities which can be detected, and then ultimately actual myocardial necrosis and cell death occurs, and this is typically something that is completed in 4 to 5 hours after the acute occlusion. However, that's not always the case. In fact, it's probably often not the case. It's probably quite common that vessels occlude and then are recanalized by spontaneous lysis of the patient's own lytic enzymes present in the blood. These vessels may recanalize on their own. They may recanalize incompletely, or the patients may have developed collateral resources. And this image on the lower right here demonstrates a person who's had the right coronary artery completely occluded, but all the distal ramifications of the right coronary artery have been supported and you can see on a direct injection of the left coronary artery that collaterals are illuminating the very large posterior descending arteries. So we have left to right collaterals, which are also very common. And now with improved spatial resolution, we can often see these, and we'll demonstrate cases of this for you at the course. Arteries can develop a fixed stenosis. It can be rigid, particularly if it's been there for a while and has some accompanied calcium in the wall of that fixed stenosis. And this is often results in the predictable clinical event of classic angina pectoris, effort-related or stress-related chest discomfort, which is relieved by nitroglycerin. And there may be not just angina, it could be throat pain, it could be shortness of breath on exertion. And sometimes these lesions, if they're a result of coronary spasm or if they're a result of plaque inflammation, they can completely regress and the lumen can appear totally normal as it does in the right side. Angina can be relieved, or atypical chest pain can go away. But typically a lesion like this is one in this particular location, which is in the proximal left anterior descending artery, is one that certainly if symptomatic or if there was a large ischemic burden demonstrated on physiologic testing would be an excellent target for a coronary balloon intervention and perhaps a stent placement. Here in the lower right corner, a simple balloon angioplasty was performed. But I would just like to remind everybody that these proximal coronary arteries where the plaques tend to occur and get into trouble are large muscular vessels, and the plaque can be of great substance and can develop with a lot of vascular remodeling and outward swelling of the vessel wall. But if a plaque ruptures, there are a certain amount of thrombus which may be variable, and there can be a certain amount of muscular tone in and about this inflamed, ulcerated culprit lesion. That's called a culprit lesion for purposes of discussion. And this can be very variable. There may be partial lysis of a blood clot. There may be relaxation of inflammatory-based spasm. Either phenomenon may cause atypical chest pain. In other words, chest pain that because of the dynamic temporal nature, it can flare and change over the course of hours or minutes or days. These are atypical chest pain syndromes that are much more difficult to diagnose and are not easily clinically recognized. So understanding a bit of the morphology of the clot, the tendency of the artery to have dynamic muscular behavior, which will alter the lumen characteristics. These will often, is probably often the basis that explains why plaques that otherwise do not appear severe may become involved with various chest pain syndromes, both typical angina and then what we would call atypical chest pain. And here's an example of how nitroglycerin can just affect the size of the coronary vessels. For example, it's been given to a person, the angiogram on the left is pre-nitroglycerin, the angiogram on the right is post-nitroglycerin, and you can all see that the arteries are much larger. We almost uniformly give everyone nitroglycerin, holding it back in case the blood pressure is particularly low or if patients have taken erectile dysfunction medication recently. But typically nitroglycerin makes the arteries bigger, and you can easily see the dramatic response of coronary arteries to nitro here, and why we like to use it to enhance the size of the vessels for CTA imaging. But I would also say that we have a problem with just pure luminography. This slide is part of the writing has been obscured by the photograph, but just to complete this, there's really no information about the wall of this vessel. In other words, the plaque is on the wall. It's the plaque and the plaque behavior which is going to determine whether or not platelets and fibrinogen is recruited into a thrombus, and yet we really see no evidence of that. So we projected direct cardiac catheterization information. We don't have lumen information, or we do have lumen information, but no soft tissue information about what it is that we're actually trying to determine therapy for. CTA, the story is totally different. We've got three images here, a normal vessel on the left, what appears to be a very severe narrowing of the contrast column here in the mid vessel of the right coronary artery, no calcium present at all. But there's a soft tissue density, which we can see replacing the area where normally lumen is present. And then in the illustration on the right, we can see quite a bit of soft tissue information. The entire proximal segment of this coronary vessel, whichever one it is, exhibits an eccentric plaque, which is subsegmental, but it has got areas of calcification. There might be a little staining from contrast in a plaque ulcer. This may be early calcification, but we have a lengthy eccentric, non-obstructive but complex plaque that harbors some of the elements of instability. In other words, when studies are done trying to look forward and say, is there a way by CT to characterize plaques which may not be obstructive but might be clinically important? We can look for this sort of information with CTA and recognize the abnormalities in the wall of the vessel that do accompany the potential risk of what could be a culprit plaque in later time. Patients like this wouldn't necessarily, by current practice standards, go on to have a interventional procedure performed, particularly if it could not be shown to limit flow. But our thinking about how to treat plaques with a high likelihood of becoming unstable in the future is changing. And I would like to predict that as we are able to image non-invasively these plaques with better and better resolution and learn more about associated perhaps biomarkers that accompany and reflect manifestation of an unstable plaque blood milieu, I have a feeling that we will begin to put stents, perhaps some of these biodegradable stents which are coming along soon, and we will begin to go ahead and stent plaques that have a high likelihood of becoming a dangerous plaque, particularly if it's an proximal portion of an important vessel like this one is. So let's talk just briefly about calcium scoring. It's important, and it's really a good screening test for the detection of coronary atherosclerosis, being basically 100% specific. So as a screening tool, it's probably a good test in many patients, particularly if you're on the fence about whether or not they should be treated with drugs targeted to change the natural history of atherosclerosis. And also for patients with uncertain symptoms, with the lingering debate about whether symptoms may or may not be due to atherosclerosis. The negative predictive value and the prognostic value of a negative or a low calcium score is hugely valuable in directing patients away for a more aggressive workup and perhaps an angiogram to make sure that patients are normal. CTA really does not have a role, certainly does not have a clinically proven role in a screening position, but calcium scoring does. CTA, on the other hand, totally different animal. We have various ways of rendering the images, and now with IV contrast, and we can have maximal intensity projected images there showing a right coronary artery in its entirety with a patent stent, or we can have these wonderful 3D rendered colorized volume views with various amounts of editing to take place. And we're given these wonderful tools to be able to organize and to use these various tools to evoke different bits of information about the coronary arteries. So just remember, it's a highly sensitive test. It's very specific in determining severity now. It's very specific in localizing lesions. And it's becoming highly specific in determining plaque morphology. And also, of course, whatever your measure, the extent of disease that can be actually seen is a wonderful tool in determining the prognosis of a particular patient. Also, now we mentioned that there's business in the wall that we can see, but I did want to point out that it's very easy to detect thrombus, and a large thrombus burden can be seen directly. Here's an axial reformatted image we're looking at in the foot orientation here on the left, and here's the corresponding angiogram with the left anterior descending, very densely involved with thrombus material here approximately. So what is our toolkit exactly? We have 3 different interactive tools, and you'll be learning these mouse-driven tools, interactive imagery that we create to go ahead and to analyze the image volumes that have been created from the CT angiographic scans. The first is a volume rendering technique, maximal intensity projected images, multiplanar and curved planar reformatted images. We'll get into these in detail, but the vocabulary is important, and there are certain circumstances where one viewing protocol is better than the others. Here I would just point out that the VRT technique really renders things looking very biologically familiar. The, the middle channel shows just the extraction of all contrast containing elements, so we have the ascending aorta, the root, and then the major coronary arteries with the absence of all of soft tissue, or if it's important to sort of get the familiarity with the great vessels, the arch vessels, pulmonary artery, etc. The lower right image there will show this. So it's a very good tool for coming up with the relationships of vessels, but it's very easy to exaggerate or to de-exaggerate actual stenosis of the coronary arteries. So really for coronary assessment, apart for tracking pathways, it really isn't a terribly useful tool. Certainly for congenital heart disease and for post-operative assessment of vein grafts. In the case on the right, there's a left internal mammary coronary artery originating in from one of the great vessels on the left side and implanted down to the left anterior descending. We can track that vessel nicely in its pedicle, see the vascular clips and the anastomosis nicely. And then the situation on the left is an atrial septal defect, the rarest kind. This is an unroofed coronary sinus. So we'll have a chance to look at a lot of these cases and bring you to a very nice familiarity about reading these and interpreting them. And here the visual, the VRT mode is very, very useful. Beyond that, we use maximal intensity projected imagery. Here we go ahead and select a slab of slices in a particular plane of obliquity that's meant to be orthogonal to the area of interest. In this case, on the left lower image there, we have the right coronary artery showing numerous areas of plaque, but no real evidence, at least in this view, of any non-calcified plaque. Perhaps there is some. We'd have to look at it more closely, and we will in the cases that we review. But here we can easily see this large vessel diseased in all three segments, but probably not with actually flow-limiting stenoses. On the lower right column, on the other hand, we have a large vessel. I don't know the orientation. I'm not sure which vessel this is actually, but you see contrasting elements now. And in the wall, we have large soft tissue encroachment on the lumen. This vessel is swollen. There's very low Hounsfield density components. There's spotty calcification in a long segmental segment of this vessel. And this would be a very highly concerning plaque to have in your patient, and one that would really prompt aggressive investigation and aggressive therapy that might even include the placement of a stent or bypass surgery. Multiplanar reconstructed images are basically the raw data. Remind you that all these pixels now are recreated as uniform measured cubes. They're about 4.5 to 5.5 millimeters in dimensions, and we can use the tools to create any plane of orientation. We may have an axial planar reformat. We may have a sagittal reformat, or we can have any number of millions of different planes of obliquity that look orthogonal to the area of interest, and in this case, an anomalously arising left main coronary artery here, and an anomalously arising right coronary here, which importantly is traveling between the pulmonary artery and the ascending aorta. And there are circumstances when this might be a dangerous lesion that would predispose the patient to symptoms and perhaps sudden cardiac death. Anyway, on these images, each pixel has a Hounsfield number. These have been windowed and leveled in a way that's pleasing and where you can find the fine anatomical detail and resolve the edge detail that's necessary. If we do maximal intensity projected images of this particular area, looking for this particular anomaly, we might not see it because of overlapping pixels that are recruited into the image. So it's very important when you're looking at fine detail to get a viewing orientation that's orthogonal to the area of interest, and then use the thinnest possible slice, and that would be the multiplanar reconstructed images. And of course here we have use of MPRs, which have now been sort of pressed onto one flat panel. In other words, the entirety of the vessel by its center line has been extracted, and these vessels can now be rotated around and viewed from different angles, and these curved planar reformations will show the entirety of the vessel, some distortion of the adjacent cardiac structures, but a nice ability to easily rotate around and read the severity. We have graft stenosis here in the lower left, and we have in-stent restenosis in the right image. Artifacts are common. We devote a lecture to artifacts and recognition, but respiratory motion, blur artifacts, blooming artifacts, all these are common. You must be aware of them. Normally we have good ways of studying an image to detect whether or not what we see is artifactual or what we see is real, and we'll discuss these in much greater detail. In terms of reporting, I would just mention just a quick reminder that there are standards, and each one of the coronary artery segments has a name. You can choose to use them, or you can choose to very subjectively describe the vessels and their courses. But this is just a slide up here to refresh your memory about the naming of 1 to segments 15, which are part of the American College of Cardiology naming conventions. And the business of reporting is something that's the most important part from your point of view, because you are going to be the ones communicating the significance of these findings. So the vessels need your report really should enable the recipient of this report knowledge to be able to sort of visually see exactly what you're describing. And each vessel has an origin. It has a particular size, which may be normal or small or particularly large. And they will have branches. And lesions that are most important, of course, are the proximal lesions, and these will be the ones that should get the most of your attention. Is a lesion ostial? Is it in the mid-segment? Is it distal? And is it a particularly bulky plaque? Is it focal, or is it segmental? All plaques basically are eccentric, so I sort of leave that out of my vocabulary. But I do try to characterize them as whether or not they're non-calcified, mixed density, or whether they're calcified, heavily calcified with confluent calcium, or whether they're spotty calcification throughout the plaque segment. And also it's very important to look for remodeling of the vessel, that is swelling and outward expansion of the vessel. This is independent of what the lumen may look like, but it's this positive remodeling that seems to be one of the features, one of the CT features of plaques which are apt to become unstable in the future. And I think it's very important. What people really are waiting for is your description of whether or not you can judge the stenosis of a vessel. And we avoid putting numbers on there, but we do have the understanding that a 50% diameter reduction is something that best characterizes a lesion that is likely to be flow limiting if it's fixed at that amount. And remember that a 50% diameter reduction is actually a 75% pardon me, model reduction in cross-sectional area. So given that finding, we use the categories of vessel as normal, minimally diseased, or mildly diseased, and these are all lesions that we would expect to be non-obstructive. Stenosis or narrowing that appears to be moderate or severe are ones with a greater than 50% diameter restriction, and these are lesions that we consider obstructive. And so that's sort of the break point: greater than 50%, less than 50%, moderately severe or severe diseased vessels are likely to be obstructive, and that's the way we report them, rather than add saying this is a 35% or this is a 40% or whatever. We use normal, minimal, mild, moderate, or severe. I'll give you two examples and then wrap this up. Here's an example of what I would call minimal disease. It could be a mild disease, that would also be correct. But basically, my comment about this vessel, I don't see it in its entirety on this image, but I would say that the right coronary takes a normal anatomic origin. There is focal, non-calcified, and non-obstructive plaque present in the proximal and middle segments of this vessel. So in asking the question, is this vessel normal? No. Is it minimal? Well, maybe mild. Whatever. It's in the non-obstructive category by whatever adjective you choose to use. Either minimal or mild would be correct in this case. Another example would be this lesion, roughly in the same place. And here I would say the right coronary artery has a normal anatomic origin. However, the proximal segment exhibits extensive mixed density plaque, which is likely to be obstructive, that is severe at several locations. I'd like to wrap it up at this point. You've been patient to listen. I thank you for listening. And on behalf of all of us at Chandler Regional Hospital, we look forward to welcoming you all to Phoenix. Thanks for listening.